So welcome to this session, how the QFR in cathlab can help us to assess non-invasively the coronary physiology. So I am Martine Chila, interventional cardiology from Brest, France, and it's a pleasure for me to be with very expert in the field. So Professor David Leisner from Berlin, Germany, Dr. Hernan Meria Panteria from Madrid in Spain, and Dr. Romain Didier from Brest in France. So as you know, besides the invasive FFR, the QFR adds a functional component to coronary angiography by using a computer simulated ADEX. So the objective of this session was to emphasize the importance of a non-invasive physiology. The second one is to learn how to integrate QFR in the decision making for the process of PCI. And the third one is learn how to perform QFR. So first of all, I think it's we recorded a case in Brest, and Romain Didier will present you the case and the record video of the case.
So thank you, Martin. It's a real pleasure to share with all of you our cases that we have performed initially recorded. So we go through the case directly. So it's a 72-year-old female, no relevant past medical history. We can just mention hypertension and dyslipidemia. And she comes from, in our hospital, from non-STEMI presentation, but we notified that we had just moderate troponin elevation. The EKG didn't present any relevant modification. So we go directly to the angio. So you see here the right coronary, of course, and you have diffuse disease, little calcification, as you can see. And in the first part, we see a tight stenosis. And for the left coronary, we see also diffuse disease with moderate, but we estimate moderate angiographically, moderate lesion and LED. So the initial plan was to assess the LED with QFR, functional test, and to treat the right coronary directly with angioplasty. This is the initial plan. So I can show you how to perform QFR on this left coronary. So you saw the first angiography, the first view, and now we will find the second view. In order to do that, we will help us with a dedicated software process. As you can see, it's an online assistant. They will help you to show the best secondary incidence. So you go on the green, you can see you have a lot of multiple incidents are possible. Don't go on the red because this gives you an incidence that are not correct for the interpretation. Here, this is a second view, as you can see here, another projection. And so now we will go in the analysis. As you can see on the right part of the screen, we are online. We go on the cathlab directly to do the analysis on the screen of the cathlab. So now we have the two views, and we will select the end diastolic phase. In order to do that, here it's relatively easy because we have the EKG is recorded. Sometimes it's more difficult, but here it's relatively easy. And we show the end diastolic phase for the two view. Now we need to link the two view. In order to do that, we select a landmark point. Usually it's a bifurcation, like here, the diagonal and the LED. And we use a secondary point in order to double check if it's correct. So here we double check with another bifurcation point, and we see it's not totally perfect. So we do some slightly modification in order to perfectly synchronize the two view. So now the two views are synchronize. So we need to determine the trajectory. So in order to do that, we will select the proximal point here and the distal point, and we will see the trajectory. Sometimes it's not correct. We need to readjust, as you can see on the left part of the screen. So we readjust here, and the trajectory is not correct at the end. They go on a diagonal, so we need to modify. Then now we go for the contour. So this is very an important element of the analysis, because if you do too many modifications, you will have also different quality of the QFR. So we do as less as possible of the modification. So here we do modification on the bifurcation, but because the contour is too much. And then we'll have this result. This result is a 3D reconstruction of your coronary, as you can see on the left part of the screen. We can roll it and see all the coronary in 3D. So they identified in red the stenosis that we initially determined as intermediate. As you can see here, you have a red marker. The red marker is where the tight stenosis, the more thinner lesion that we identify. And we need to determine on the right part of the screen where is the reference part of the vessel in terms of diameter. So we say here the first part of the artery, this is the part is normal, and at the end also this is the reference. When we have done that, we need to go for the first analysis. As you can see, we need to use frame counting in order to count the advancement of the contrast through the artery. As you can see here, it's done automatically. And you have the result. Here is 0.86, but we say it could be borderline, but in our center, we accept this result and we say we can differ the result for this patient on the LED. So we are satisfied with that. You can see here you have the result, a report for the patient. The patient come at home with this report. You can give to the general practitioner or other people. Here we go on the right. I mentioned at the beginning we plan to treat directly the right, but finally we say we are doing QFR, so we can do just on the right in order to test it if we find a significant result. So firstly, we are looking a second view. As you can see here, we are trying to find the second view with the online assistant. And then when we have the second view, we done all the steps. So end diastolic phase for the two view, as you can see again. Then we will have the trajectory. So we need to synchronize the two view. Here, as you can see. Then the trajectory of the artery. So we need to select the proximal part and the distal part here. And then the contour as well. So this is an important point you can look at, because at the beginning we were really thinking that this lesion is very tight, but we should treat. So we probably overcorrect too much in the two view. As you can see, we do probably too many corrections. And we find in red here a very tight stenosis, probably artificial. So we put the reference as well of the vessel, the distal part, and the proximal part that we say it could be normal. Okay. And then we do the frame counting. So the automatically frame counting in this case doesn't work, so we do manually. So we say here this is the end of the vessel, and we record the frame. the number of frames since the beginning of the injection. And finally, the result, so we need to choose, was 0.83. So
we decided to perform a FFR because it's we are not satisfied because QFR said it's not time. So we perform a QFR, the FFR, and as you know, you have to make a calibration. You have to shape in the tip of your FFR. Here it is the calibration, and then we make the measurement. You know that you have to avoid the ventricularization of the proximal pressure, meaning that the guiding induce a functional stenosis. So after injection, the guiding should be pulled back into the aorta. So we do that. Here it is the injection. And now we check. And so there is a large pause. We have no pause when we perform QFR, but we can have a pause when you perform FFR in the right coronary artery. And as you can see, the result of FFR is we surprised it because it was just around 1. So no stenosis at all in this right coronary artery. And you remember we modified the way to make the QFR because we are very sure that there is a stenosis. So we modify the contour of the QFR in order to find something. But even with that, the QFR said it's not time. So we perform FFR. FFR said it's not time. So we do, and we check the drift of the FFR because with FFR there is a drift. With QFR there is no drift. So we begin again the analysis of the right coronary artery without modify the contouring. So Romain.
So yes, we do it again because we are Britain, so we want to have the same result for the two methods. So here you can see again the contour that I mentioned already. That is really important point of the procedure. So probably we assume that we have done too many modifications. So what we done on the left part, we see perfectly the lesion, so we correct regarding this lesion, but not so much on the right view because we don't see so much the stenosis. So we do the reference at the same, and with this less correction, we find a very different result, like 0.89, like similar to FFR. 99, similar to FFR probably. So we overcorrect the contour too much.
So thank you, Romain. So I think it was a very interesting case, because when you say we need to have to perform a QFR in a very, very strict and stage analysis. So I give the talk to Hernan, to Hernan in order to explain how we can do and the tip and tricks of how to perform a QFR. So Hernan is yours.
Okay. So thank you, Professor Gillard. It is my pleasure to be here with all of you. So first, it is important to remember what is QFR. And as you know, QFR is an angiography-based technique that was developed to predict invasive FFR. And for doing that, we first obtain a three-dimensional reconstruction of the target vessel using a dedicated software over which a mathematical approach is applied for a fast computation of coronary flow through the lesion, finally obtaining an estimation of what will be the FFR. So at the end, QFR is based on angiography, and therefore we need to keep in mind that its accuracy will depend on optimal image quality. So let's see some tips and tricks that I want to share with you and that are very important to perform an accurate calculation of QFR. First, before acquiring the first QFR dedicated angiography, it is very important to give intracoronary nitro to avoid any QFR overestimation. And the principle is the same when you are doing invasive FFR measurement. We need to control the epicardial vascular tone to eliminate any potential vasoconstriction that could overestimate the QFR severity. And therefore, whenever possible and the patient hemodynamic condition allows, inject intracoronary nitro before the first QFR dedicated angiography. The 3D model of the target vessel for calculating QFR is constructed using two views, as Dr. Didier has shown. And for doing an appropriate three-dimensional reconstruction, it is extremely important to select an adequate second X-ray view. And for selecting such adequate second view, we need to follow two instructions. First, both X-ray views must be apart at least 25 degrees. And second, the vision angle of the target lesion must be almost orthogonal between the two X-ray views. And this is the value of these yellow lines that the software displays when we are choosing both angiographies. If these yellow lines are parallel to the lesion, as in this case, the 3D reconstruction of the target lesion will not be accurate because we are probably losing an important part of the lesion geometry. But if you select a second view for which the yellow lines appear perpendicular to the lesion, as in this case, for example, the second view should be the LAO 2 degrees with cranial 6 degrees using the software acquisition guide, then you will obtain a reliable reconstruction of the lesion geometry in 3 dimensions. Besides, it is also important to avoid excessive foreshortening. We can have two views separate more than 25 degrees, for which the vision angle is perpendicular to the lesion between both views. But despite that, you also need to pay attention to the foreshortening. For example, the second view in this case is not appropriate because the vessel segment has a foreshortening of 46 degrees, which obviously will affect the three-dimensional reconstruction of the vessel. Therefore, in the process of selecting the second view, we need also to avoid too much foreshortening. So my tip number 2 is related with the process of selecting the second view. Follow the recommended X-ray views. In most of the cases, we can obtain optimal complementary views applying these angulations according to the type of the target vessel that you can see in this table. Or better yet, you can follow the software acquisition guide as it was demonstrated by Drs. Didier and Gillard with their case. It is also very useful, this tip related with the catheter and the contrast. Fill the catheter with contrast before angio acquisition, because otherwise, as you can see here, the contrast vessel filling will not be homogeneous, and this will difficult the frame counting analysis, which is necessary to calculate the contrast QFR value. But if you properly fill the catheter with contrast in the right image before angio acquisition, you can more easily follow the column of contrast at each frame of the cine, and therefore you will obtain a more accurate contrast QFR value. And this is my last tip related with the angio quality. You have to be sure that the target segment is properly centered, avoiding excessive zooming, and do not move the table during angio acquisition. And this is very important because otherwise, as you can see here, maybe you cannot find a feasible end-diastolic frame for calculating QFR. On the contrary, if you center properly the image, and if you don't have excessive zooming, and you don't move the table during cine, you will have a lot of chances, as you can see in the right video, to find an optimal end diastolic frame. And let's see now some tips and tricks related with the QFR measurement. We need to select the end diastolic frame in each view, and when the EKG signal is available, this step is extremely easy and fast because the software automatically will show us the end diastolic frame. But if the EKG signal is not available, you must find it manually something is not going good with is not going well with the right video. But in any case, when you don't have the EKG signal, you must find it manually, and this step could not be so easy when you are analyzing the right coronary artery. And in such case, you can be guided paying attention to the contrast into the aorta and the aortic valve. You need to stop the movie in the frame when the aortic valve is open and the contrast is in the aorta, and usually 2 frames before that, you will get the optimal end diastolic frame. But this is something that will be facilitated soon by all the developments that are still pending to come in. I can anticipate that the developers are right now testing an automatic detection of the end diastolic frame without the need of the EKG signal using deep learning methods. When on the other hand, when you have the preliminary 3D reconstruction of the vessel, you still have a chance to improve the quality of the 3D model. And this step is called the correspondence, because you need to be sure that both the minimum and maximum reference diameters are properly matched. For example, you can see in this case that there is some desynchronization at this part, and this is something that should be corrected because indeed this is the target lesion. You just need to move this blue marker in one projection and place the same marker in the other projection at the same position. And you see now how both reference diameters are better matched at the end of the video. It is also important to be not too much obsessive with modification of the contours of the vessel at the lesion, as Professor Gillard and Dr. Didier has shown us, especially for tight stenosis. Unless you consider it necessary due to gross deviation of the contours, do not modify the lesion contours, because otherwise a minimum change, as you can see here at the lesion, can cause an important modification of the QFR value. In this case, this is not too much relevant because in both cases we obtain an ischemic value and therefore the clinical decision will be the same. But if you are facing a very new value to the cutoff, then you can cause a change in the revascularization strategy. The following slides are related with the site to place the start point for the segmentation of the vessel. If we are facing a left main stenosis, obviously you need to start the segmentation proximal to the lesion. But be cautious, because remember that we should not assess ostial left main stenosis, because in that cases we cannot obtain a reliable proximal reference diameter. But if the left main has not a significant lesion and the target stenosis is in the LID or in the left circumflex, you don't need to place the start point in the left main. You can start the vessel segmentation in the proximal LID or in the proximal left circumflex. If your main target lesion is in the LID or in the left circumflex, but there is also a concomitant significant left main stenosis, then you need to start the segmentation proximal to the left main stenosis. And if the target lesion is located in a secondary branch, like this diagonal branch, for example, you may start the segmentation in the main branch, but importantly, the proximal reference should fit the diameter of diagonal branch. Otherwise, if you fit the reference diameter to the LID, you may overestimate the QFR severity. And finally, if your target vessel is the right coronary artery, be sure that the start point is not placed proximal to the catheter, because otherwise the frame counting analysis for the contrast vessel QFR could be unreliable. And remember, as with the left main, the ostial right coronary artery stenosis should not be evaluated with QFR because the same reason, the proximal reference diameter for aorto-ostial stenosis would not be easily determined. This is a summary of the recommendations for an optimal acquisition of angiography aimed to perform QFR analysis. Put the acquisition frames at least at 12.5 frames per second. This is necessary to detect with accuracy the contrast filling frame by frame when you are performing the frame counting analysis. Fill the catheter with contrast before angio acquisition, as I showed you before. And if you are not using an automatic injector and you make manually the contrast injection, be sure to make a brisk contrast injection for at least 3 cardiac cycles. Do not move the table during the cine, and try to select the angle views without overlapping of the target vessel. Let's see now some QFR limitations. in some anatomical and clinical subsets, like true bifurcations, graft vessels, presence of collateral circulation involving the target vessel, atrial fibrillation, culprit lesion of an acute myocardial infarction, and severe cardiomyopathies, the accuracy of QFR has not been widely investigated, and therefore, by the time being, it is not recommended to use QFR in these scenarios. And in addition, there are some anatomical conditions in which QFR cannot be performed with accuracy, including aortostial stenosis, too much overlapping, too much foreshortening, and severe tortuosity. And in hyperdynamic conditions, in the same way that it occurs with invasive FFR, the flow can be increased, and then the QFR value could be overestimated. And this is my final remark. The main message to take home for me is this: remember, because it's very important. This is the cornerstone of QFR. The better the image quality, the higher the accuracy of QFR.
It's great, and I think you summarized all the tips and tricks, and I think the audience could have a good overview of how to perform a QFR. So you have to ask a question. You can ask question on the chat, so do not hesitate. We have just one question for the answers, but we ask it during the last session of this webinar. So now we go with David in order to know in which case in our clinical practice we can perform QFR.
Yeah, thank you very much. Also from my side, good evening. I'm very pleased to support today this meeting. Maybe we can go to my slides. I really like to talk with you about QFR this evening, since I'm 100% convinced that QFR being a very important step forward to achieve the goal of precision medicine in the interventional treatment of coronary artery disease. And therefore, I'm very happy to share with you some thoughts about the question, when should we use QFR in clinical practice? And when you ask me to talk about this topic, I remembered what are my personal top 3 indications where I use QFR in clinical routine. And I want to present you to each of these indications now one clinical case, starting with the case of a chronic coronary syndrome of a patient with an intermediate lesion. This is the most important and the most frequent indication where I do QFR without a prior evidence of ischemia, for example, from stress MRI or stress echo or something like this. And in this context, I want to present you the case of a 55-year-old male patient with chronic coronary syndrome. He has a known 2-vessel disease. He has atrial fibrillation, paroxysmal. He has a renal function which is decreased. He has asthma, so this is an important point where you want to be very careful with adenosine and with invasive measurement by FFR. And he has a lot of cardiovascular risk factors. And he presented to our department with angina, and there was a bicycle exercise testing done by the primary physician, and he saw some not very clear ischemic signs in the ECG, and so he sent him for coronary angiography. And as you can see in the on the coronary angio, on the left side, you see the LAD, and you see there's a stent in, and before the stent, there's in the proximal part intermediate stenosis, and you see the right coronary arteries only with plaques without any severe stenosis. So in this situation, you should ask the guidelines, so you should think about the guidelines, what's to do in this situation. You have an intermediate stenosis in the LAD, and so the question is how to treat, and the guidelines say you have to produce evidence for ischemia in this situation. So normally you should do this invasive by measuring FFR or one of the, like EFR, one of the other indexes without adenosine. In this case, you also have the possibility, and you see a very nice example before, to do a very fast and a very easy computated evaluation of the hemodynamic relevance of the stenosis by measuring QFR. And we saw the QFR in this situation has a lot of positive things. It's only angio-based. It's not less invasive. It's very fast. You don't need another pressure wire, and you don't. And I think this is a very important point. You don't, especially in this patient, there's not the need to produce hyperedemia with adenosine. And so, is QFR only a method, or is there also scientific evidence? QFR is quite a young method, but there is scientific evidence, mainly from the two pilots trial. This was the FAVOR-1 pilot study, which was done mainly in Europe, and on the other side, the FAVOR-2 trial, which was mainly done in China. And both studies were very important because they could show that there's a very good correlation between this angiography-based QFR with the invasive assessed FFR. And second, and I think this is most important, there's an excellent diagnostic accuracy of the QFR for the detection of hemodynamic relevant coronary stenosis. So I talk to you that this is one of the positive things of QFR is being very fast and doing this very easily. And this was also analyzed in the FAVOR-2 study, where the comparison was done between the time you need in your all-day practice to perform FFR as compared to QFR. And you can see for a QFR, there's a median time of about 5 minutes as compared to 7 minutes with the FFR. So you also have a significant difference, and you being faster in your clinical routine. So this is important to use this. One very important scientific evidence is missing, especially an outcome trial is missing. And so I'm very happy to say you that there's actually recruiting the FAVOR-3 trial, which is done in Europe as well as in Japan. And what they investigate is exactly as an outcome trial. They compare in a 1-to-1 randomization 2,000 patients to QFR as compared to FFR, with a primary endpoint being MACE, so a clinical endpoint, which should be not inferior for the QFR as compared to FFR. So second indication, this can be used in chronic as well as in acute coronary syndrome. You are able to calculate or to measure by QFR the efficacy of your therapy of the PCI by measuring the post-PCI QFR after treating the target or the culprit lesion. Again, with a clinical case of a 63-year-old male patient with non-STEMI. He has a free vessel disease, and you can see the angio on the left side, again, the left coronary syndrome. It's quite clear that there's a culprit lesion in the mid part of the LID, and on the right side, you see the right coronary artery without any problem. And so what we did PCI of the LID, which was quite easy. And after this, we calculated the QFR. You see angiographically a very excellent or perfect result with a bit of plaque in the proximal part. And we calculated the QFR, and this is 0.87. So this is over a cutoff of 0.8, but it's not normal, not 1.0. So what does this mean? And there's also a very recent study from Italy. They investigated exactly this, and what they found are two main arguments or two main points. On the one hand, if you have a post-PCI QFR value over 1.89, you can be sure that there will be not an adverse event in the follow-up time of, in this study, 2 years. But if you have, as in our case, QFR value below 0.89, you have a threefold increased risk of a vessel-orientated clinical endpoint of an adverse event in the vessel you treat. And what they also analyzed, and I think this is very important, they try by analyzing the pullbacks of the QFR, they analyzed how the pathologic QFR is caused by, and they saw there's in most cases a diffuse disease, as in our case, which is responsible for it. And the clinical consequence, I think, from measuring such a pathologic QFR after PCI would be a most intensive secondary preventive, including mainly for a very long time or lifelong dual antiplatelet therapy. So I'm going to the third indication I told you. Is it just a study or is it clinical reality? This case I presented you came exactly 1 year after measuring this non-perfect QFR back, again with a non-STEMI, and you see the progression of the atherosclerosis exactly in the region where the diffuse narrowing of the vessel was before, and we treated it once again. So you see, it's not only study, it's really reality to make an effective risk stratification for your patients. We did it more for academic reasons to measure again the QFR after 1 year, and you see it goes down to 1.55. So not only the angiographic findings were worse, also the QFR is worse and pathologic now. So third indication is how you use it, and I think this is a very interesting, actually increasing indication, how to use QFR in the setting of acute coronary syndrome, not to control or to check the result of your PCI. More than 50% of our patients have three-vessel disease, to make an easy and wireless evaluation of the non-culprit lesions. And I have a clinical case for you of a 53-year-old patient with acute coronary syndrome with the three-vessel disease. And you see again the coronary angio culprit lesion. It's quite clear as the thrombotic occlusion of the distal part of the right coronary artery. For the left side, for my personal impression, I would say everything is fine, a bit of plaque in the circumflex and in the LAD. And now an example we measured in this case after treating the acute coronary syndrome. So the examination is finished, and we do it during we write our report for the cath, and we see there's a pathologic QFR value in the circumflex with 0.79, and therefore this lesion was intended for second staged PCI in this non-culprit vessel. I'm very pleased to tell you that we investigated this in a big study which was published, I think, a week ago in Circulation Cardiovascular Intervention. We take more than 700 patients with acute coronary syndrome that underwent PCI of the culprit lesion, and we do two things. On the one hand, we do a final QFR assessment within the culprit vessel, and add-on, we investigated all non-culprit vessels where we have not a clear stenosis intended for a PCI procedure, and look how this QFR can be or can bring you to prognostic relevant information. And these were the results we investigated and we established in the study cohort of more than 700 patients with acute coronary syndromes, two ACS-specific cutoffs, one for evaluating the quality of your culprit vessel. If you have a value over 0.89, you can be sure that there's only a very, very small probability for a MACE event in the culprit vessel. And for the non-culprit vessels, there's a cutoff of 0.85. And so and this is in the multivariate regression analysis, and I think most important, and telling you that for my impression, this is really an important point to achieve precision medicine. The QFR with the two different cutoffs for vessel for the different types of vessels was the strongest predictor to predict MACE within 2 years of follow-up in this cohort. So I think it's really a great tool for risk stratification and acute coronary syndrome. And with this, I hopefully give you an impression for my top 3 indications where I see QFR in the clinical routine. Thank you.
Thank you very much, David. It was very, very clear. So we have some questions from the audience before, because we have also some clinical case, over clinical case, but we have some questions. So perhaps for Hernan, for the tip and tricks, one of the audience asked if we need an injector to perform the angio of the QFR, or can we do it by hand?
Oh, that is a very good question. I think that, as I said before, if the important thing here is that if you do it by your hands manually, it's important to make a brisk injection and make it a cine at least during 3 cardiac cycles. And of course, you can do it manually. In my clinical practice, for example, we have the automatic injector. So we use one setting for the left and another setting for the right. But of course, we also have experience doing some cases with manually with a hand injection. And if you are doing a brisk injection, at the end, the precision of the QFR will keep very high. So I think that at the end, the important thing here is that you obtain a high quality image angiography.
Thank you very much. So for David, another question. So you talked to us about the cutoff of the QFR. You said first 0.89, then 0.85. So the audience wants to know, because we have a lot of questions about it, wants to know what is the real cutoff for the QFR, and if there is a gray zone, what do you need to do if the measurement of the QFR is on the gray zone?
So actually, maybe it was a special situation where I presented you the 2 cutoff. It's just to make it clear once again for the setting of acute coronary syndrome and for the situation, the QFR post-PCI in the carpet lesion, as well as for the non-carpet lesions, to evaluate them within the setting of the acute coronary syndrome. So to make it very clear and educational clear, the official cutoff for measuring the QFR actually in the setting of chronic coronary syndrome and so on is 0.80. So according to the FFR. So this is what is validated, and the FAVOR trials and also the FAVOR-3 trial as an outcome trial uses exactly this cutoff to differentiate whether you have to treat the lesion or you can observe the lesion. So actually there is not a gray zone, because I showed you if you use this cutoff of 0.80, you have a more than 90% accuracy as compared to the FFR. So I think this is quite good for this, and we will see in the FAVOR-3 trial whether this is also clinical meaningful with this cutoff. But I have to say, in my personal experience, if I have someone with a classical chest pain and I have the situation that I measure QFR of 0.80 or 0.81, I additional measure FFR, and importantly, I've never had a case. I would say 10 or 15 times this situation. I never had a case where the FFR was positive, then the QFR says it's over 0.80. So you can be sure that using this cutoff, it's really a good differentiation among treatment or observation.
Thank you very much. So perhaps we can see a clinical case, because we answer to the principal question of the audience. So perhaps, Anand, you can show us a clinical case. Okay,
sure, thank you. Yeah, so let me present first this case. This is about a 65-year-old male with hypertension and dyslipidemia, and a clinical presentation of typical stable angina. The echo and the EKG in this case were normal, and a clinically indicated angiography revealed 2 intermediate stenosis in the proximal and the mid segment of the LID. And in this case, I want to remark the value of QFR in the presence of tandem stenosis. As you can see here, the analysis automatically show us between both lesions which of them is the most significant, which corresponds to this remarked in yellow as the lesion number 2. But also, we can manually select the other lesion, and you see how we can easily identify anatomical parameters that we can use for guiding PCI, for example, the length of the lesion. But we can also see an estimation of what will be the functional result if we treat a given stenosis in the presence of tandem lesions. In this case, for example, if we treat the proximal lesion, the functional result, as you can see at the bottom, will be not optimal. The residual QFR will be 0.81 and will not be optimal because of the residual stenosis in the mid-segment. But if we treat the lesion in the mid-segment without treating the proximal lesion, the functional result, as you can see here, the residual QFR will be 0.95. It will be too much better. And this is something that we can also clearly see in this panel, which is representing the longitudinal assessment of the pressure drop. The yellow line at the bottom is depicting the longitudinal assessment of the pressure drop along the segmented vessel, and in which we can clearly observe how the mid lesion is the one that is contributing to a large pressure drop compared to the proximal lesion. And therefore, I think that QFR is also a very promising tool in the setting of tandem stenosis because it provides several tools that we can use to guide revascularization strategies. This other case is about a 60-year-old male smoker that presented with an inferior STEMI, and the culprit vessel was successfully treated with a primary PCI. However, the acute angiography revealed also in the left coronary a severe stenosis in the mid-left circumflex. And this case is very interesting because it illustrates how the functional lesion assessment of this lesion with QFR using the first acute angiography with a value of QFR of 0.92, as you can see here, indicating a non-ischemic lesion, predicted very well the invasive FFR value measured 2 days later after the index primary PCI. So in a way, QFR has the potential to avoid invasive, unnecessary second procedures in the STEMI setting using the acute angiography for evaluating non-culprit lesions in patients with multivessel disease. And this is something that we previously reported. We found that in STEMI patients with multivessel disease, the diagnostic performance of QFR using the acute angiography is high to predict the invasive FFR obtained in a second procedure. And this is clinically very useful because this technique, according to this study, has the potential to avoid a significant number of second invasive procedures. So I think that functional angiography with QFR in the setting of acute coronary syndromes is feasible and accurate, help in avoiding invasive second procedures after successful PCI of the culprit vessel, allows a complete functional assessment in patients with multivessel disease with a demonstrated prognostic value, as reported previously Dr. Leisner with this fantastic study recently published with a pan-coronary QFR assessment. QFR may shorten in hospital stay and therefore may reduce the healthcare costs.
Thank you, Hernan. So I think Romain has a question.
So yes, I have a question for Hernan. So Hernan, you show us multiple cases, but in your daily practice, you have a lot of people that come to see you in order to discuss about angio. I mean, recorded case, previous angio. Did you know if we can perform QFR in these patients? I mean, retrospectively. And if we done retrospectively, we cannot adjust the second incidence. So maybe we have some tip and tricks. So can you give us your practice about that?
Yeah, thank you. This is a very good question. I think that one of the qualities of when you have the custom of performing angiographies with a high quality is that you can use the angiographies later when you want to perform QFR analysis. So my answer is yes, of course. You can use previous angiographies to assess the functionality importance of stenosis. In this scenario, it is very important that you have a very high image quality. If the image quality is high, then you will be very confident with the QFR value. So, in fact, I can tell you that many studies performed nowadays with QFR have incorporated retrospectively angiographies in which QFR was successfully measured. And now, of course, we are waiting the results of the Favor 3 trials, one from China and the other one from Europe and Japan, in which we are doing an online analysis of QFR, as you demonstrated previously, using the acquisition guide. So if you are doing, in summary, an online QFR assessment, my recommendation is to use the acquisition guide, because it's very useful to find an adequate second view. But if you are doing a QFR analysis offline, then you can use previous angiographies in a retrospective way if you have an appropriate quality of the angiographies.
Maybe I can make a comment on this. I completely agree with Hanan that this is a perfect way to do it. Maybe just if you implementate QFR in your cath lab or in your clinic, I think it's really important to train all the staff of the cath lab to make the right projections, and in every situation to have a proper imaging quality. Because then you are able to do such things as panvascular assessment of patients in acute coronary syndrome and so on. Then you really have all the basics to measure QFR in every situation and in every constitution, online and offline. So this is, I think, important if you start a QFR, to implement QFR in your cath lab, to make sure that this is done from then in a clear situation. And for example, we do here a lot of biplane angiography, then it's really easy to have the projections you need for the different vessels to do QFR analysis with high accuracy.
I completely agree with you. And for example, when you perform a STEMI on the night, during the night, and that the STEMI have a multivessel disease, you can perform the analysis of the other on the morning next day. And so I think it's very, very important to explain to all the operator to use very nicely the injection, as Hernan showed us, in order to perform QFR when we want to do it, and we can do it after. Another question from the audience, it is about the sensitivity and specificity of the QFR versus FFR. And they are, some of them are angry because there is no standardized cutoff. But you told us that there is a standard cutoff, which is 0.8. So what is the sensitivity, specificity of QFR versus FFR? You show us in your slide, but perhaps you can say it again.
So the important question is, you compare QFR to what? We did it also with a large cohort of patients in our study, more than 1,000 patients, and compare it with two things. On the one hand, to resting index, and we compare it with FFR. And with FFR, you have, and this is in line with the Favor trial, you have a diagnostic accuracy. I think this is more important than having values for specificity and sensitivity. It's more important to have accuracy, and you have it with the FFR for about 90 or 91%, with the resting index a bit lower, but also with 80% with quite a high value. I think it's not so important, because every one of you knows that the FFR is also not 100% clear. The FFR was validated against non-invasive ischemic testing. So we have now an evaluation of a new system comparing something which is validated to something non-invasive. So it's also not the 100% solution in my personal opinion. So let's wait for the FAVOR-3 trial, which is an outcome trial using exactly the cutoff of 0.80. And if this study is hopefully positive, and we can be sure that this cutoff has an important and a sufficient power to detect patients that need PCI or that need observation. And I think this is important, or more important than having an 0.91 or 92% of accuracy.
Thank you, David. And another question for Hernan. What about the fluoroscopy time? Is it comparable? The fluoroscopy, is it comparable from FFR to QFR?
Sorry, can you repeat the question?
The fluoroscopy time, the time of irradiation, is it the same? The radiation is the same from with QFR and FFR, because FFR you have to follow the wire, you have to make fluoroscopy, and for QFR, what do you think? It's the same or it's less?
No, of course, is I think it's less. I mean, we go back to the beginning. If we are doing from the beginning in our cathlab good angiography, at the end we will only need the 4 or 5 CNS that we obtain in our routine practice to evaluate the left coronary artery, and the 3 images to evaluate the right coronary artery. So at the end, I do not expect to spend more time, more than usual, when we are acquiring images for performing QFR. So my answer is, of course, I think that a QFR will reduce the time of fluoroscopy compared to FFR.
Thank you very much to all of you. I think we are arrived at the end of this very interesting webinar. So first of all, I would like to thank General Electric Healthcare and Medis for their support. So if I can summarize what we have said, QFR may provide an easier and faster method for performing physiology-guided assessment of coronary stenosis, no wire, and it's important in multivessel disease, no drift. QFR has an accuracy comparable with a pressure wire-derived FFR. And I hope that you enjoy all the clinical cases, clinical situation from the daily practice where the QFR brings us significant additional value. So I would like to thank all the experts and to thank all the audience, because you have asked many questions, and I hope that we answer it very well. Thank you very much and have a nice evening.
Thank you.